What is postoperative nausea and vomiting? Postoperative nausea and vomiting is an unpleasant complication after surgery that can affect peripheral, central, or both receptor pathways. It has been extensively researched with evidence proving the causes are based on several different factors. One of these includes patient-specific factors, such as being female, a non-smoker, under 50 years of age, and having a history of motion sickness or postoperative nausea and vomiting. Anesthetic agents also can contribute to postoperative nausea and vomiting, such as volatile anesthetics, which are an inhaled medication, nitrous oxide, postoperative opioid use, and the duration of anesthetic use. Furthermore, research suggests that the type of surgery being performed can affect the patient post-surgery, such as cholecystectomies, laparoscopic surgery, and gynecological surgery. According to the Australian Institute of Health and Welfare, Australian statistics for the 2014 to 15 financial year, postoperative nausea and vomiting affected 32.08% of patients. This figure represents 45,208 people that had this undesired complication in 1 year, which is a significant number and something that should be improved. It contributes to increased length of hospital stays, increased costs to the hospital, and ultimately negatively affects the health outcomes of the patient. This could include serious medical complications such as dehydration, electrolyte imbalance, esophageal rupture, and pulmonary aspiration. Many centuries ago, medical experts would perform operations on patients without analgesia. This would result in excessively high numbers of postoperative patients with nausea and vomiting. Did you know that remedies they would use as treatment included wine, smelling salts, and opiates, such as Batley's sedative solution of opium? Anesthetics were only introduced in the 1800s, such as nitrous oxide, ether, and chloroform. However, some of these medications have been proven to be harmful and cause serious side effects. Hence, most are now unavailable to access. Now in the 21st century, we have a wealth more knowledge and appropriate medical practice. Physical examinations are performed to diagnose patients and determine whether general anesthesia is necessary and not a local or regional anesthetic, which has less incidence of postoperative nausea and vomiting. Medical staff also take assessments of patients' predictive and metagenic factors using a risk assessment tool to categorize the patient into low, medium, or high risk, as seen on the current slide. Once this is determined, it can allow an appropriate plan to be implemented for the patient. General anesthetics with opioid ingredients have been proven to increase postoperative nausea and vomiting, so anesthetics like propofol are more often used. In addition, research has been undertaken on specific medications, such as the antiemetic ondansetron and diclectin, neurokinin-1 receptor antagonist aprepitant, and corticosteroid dexamethasone. These medications have research that suggests they are the most beneficial on the market to relieving postoperative nausea and vomiting and most limiting in their side effects. There has been controversy about whether non-pharmacological methods can prevent or relieve postoperative nausea and vomiting, such as peppermint and spearmint, supplemental oxygen, and PC6 acupuncture point stimulation wristbands and needles. Research has resulted in some proven benefits, but further studies need to be conducted to determine its benefit compared with other methods. According to the latest international guidelines on postoperative nausea and vomiting produced by the Society for Ambulatory Anesthesiology, best practice consists of several guidelines. These guidelines incorporate identification of risk factors, such as the use of the APFEL risk scoring system, reducing these baseline risk factors, administering prophylaxis in combination therapy as opposed to a single drug, and antiemetic treatment to patients suffering nausea and vomiting. The guidelines are a systematic review of information which was taken from reliable databases and clinical trials and represents the safest methods of caring for a patient experiencing nausea and vomiting. Hospitals within Australia, however, all have their own specific guidelines. For instance, the policy at the King Edward Memorial Hospital in WA as of 2015 uses medications that have been proven effective by good quality clinical trials. These include ondansetron, metoclopramide, droperidol, and promethazine in intervals until nausea and vomiting has been managed. In comparison, the Royal Perth Hospital in WA uses the same medications, however has additional options such as domperidone, prochlorperazine, haloperidol, anticholinergics, and HT3 receptor antagonists. Best practice guidelines in Australia are the hospital-specific guidelines, which have been set using their own research. There have been many clinical trials undertaken and research performed on the prevention and treatment of post-operative nausea and vomiting. However, there is still much debate over prophylaxis versus symptomatic treatments or what medications are most effective. While medical research has discovered medications that are more beneficial in preventing and treating post-operative nausea and vomiting, there is no gold standard that exists. The statistics in Australia are still very high and is a large additional cost to the government, proving there is certainly a need for change. Medical staff need to take more thorough and complete medical assessments of patients, including medical history and physical examination, to determine whether the operation or general anaesthetic are really necessary. There should be better use of the risk assessment tools to determine how likely the patient is to suffer and whether to administer prophylaxis to prevent this complication. Increased awareness and education to staff on the management of this issue is vital to communicate the need for change and strategies to implement. This includes information on most effective medication treatment options, incorporating prophylaxis and symptomatic treatment, as well as post-operative analgesia. Furthermore, implementation of national policies to standardise the management of post-operative nausea and vomiting would be beneficial to improving current statistics. Where comes change in new processes in a facility, there needs to be a willingness by staff to participate. That willingness should come from management, getting staff on board, involving them in education and programs, and encouraging them to disseminate information to their wards. Staff need to have the motivation to take extra time with their patients, constantly grow and improve their technique to limit the duration in assessments, examinations and procedures, and use available resources to make better decisions. This complication is something that can be improved should there exist some standards to direct the medical industry into the right course of action.